Welcome, everyone. I'm Leith Greenslade from Every Breath Counts and delighted to be moderating our roundtable today, the day after World Pneumonia Day. Please select your preferred language by clicking on the globe icon at the bottom of your Zoom screen. Today, we're bringing back 12 of the 38 organisations that made milestone commitments at the second Global Forum on Childhood Pneumonia in Madrid 6 months ago to report on their progress. We'll begin with a short video to remind us all of just how extraordinary that event was. Watch.
At the second Global Forum on Childhood Pneumonia, governments, global health organizations, partners, and civil society came together to make 37 bold commitments to protect all children from the leading infectious threat to their survival, pneumonia. These commitments will not only save children's lives, but help countries to regain the ground lost during the pandemic and accelerate the achievement of the Sustainable Development Goals by 2030.
Le ministère tchadien de la Santé publique et de la Prévention demandera à Gavi d'introduire simultanément en 2024 les vaccins PCV et antirotavirus.
Global health partners rallied to support countries to achieve their child survival goals.
The Gates Foundation has committed $300 million towards new vaccines and prevention of pneumonia. And it will be a commitment from the Gates Foundation at this forum that we will spend a further $200 million in the next 18 months.
And companies stepped up with bold new commitments.
I'm delighted to announce that we're going to be bringing hemoglobin technology to this device.
And today, I'm happy to announce that Hewatele will be building our first liquid oxygen plant and East Africa's largest liquid oxygen plant, 20 tons per day.
We know that the challenge we face is daunting, and yet we know what we must do.
The issue of child survival for me is not just a health issue, it's also a gender equality issue.
When the governments are in there, they're discussing actual implementation and the practical solutions and challenges they face every day. That is what has inspired me most about the meeting so far.
Together, we are determined to reach the children at greatest risk, no matter where they are.
I would like to thank all the participants, the governments that traveled from far, and that have demonstrated that they are strongly committed to pneumonia and to child survival.
Join us as we seize the opportunity to fulfill our promise to every child, a 5th birthday.
Wow. That takes you back. We wanted to refresh everyone's memory of what an extraordinary event that was. So our agenda today is fast and furious. You'll get to hear rapid updates from organisations spanning governments, UN and global health agencies, NGOs, foundations and companies. You will see the commitments they made at the forum on the screen as each speaker tells you what has happened since. There has been strong progress, and we commend all commitment makers. We ask our audience to stay muted with videos off and to make good use of the chat to share comments, reactions, and also your own updates, as we have many more commitment makers joining us, and we simply didn't have time to spotlight all of you. We begin today with one of the most inspiring commitments made in Madrid, and we welcome back the man who delivered it on behalf of the Sierra Leone Ministry of Health, Dr. Sati Kene. Dr. Kene.
Good. Can you get me now?
Yes.
Good afternoon, colleagues. In the fight to eliminate or minimize childhood death due to pneumonia and other causes, we made a commitment in Madrid and we decided to take bold steps. Strong above all was to see how we can forward with the Child Survivor Action Plan, which we developed, and to see how we can focus on child issues, and then, of course, to see how we can make oxygen available at the lowest level where possible. We have three main commitments from me in Madrid, and I'm here to give you some few things we've done. Immediately when we arrived back home, of course, I discussed with the minister who has been the brain behind and pushing us, and the whole leadership of the ministry. And we immediately launched the Child Survivor Strategy in country. We had a grand national launch, and we did not only stay there, we had to go at regional levels where every important stakeholder from local community, youths, and everybody, NGOs, were part of it, and they were done in grand style. We know child survivor issues or childhood illness issues have been within. We had a program called Child Health and EPI, but the EPI part of it, the immunization part of it, had actually swallowed the remaining. Focus was so much on that. So one of the great commitments was to really divide that and make child health a focus, and which I want to tell you that we've successfully done that. We now have a child health program, and we have constituted it. Interestingly, Dr. Linda Grant is the program manager, and similar things are happening at district levels to have focal persons that will be focusing on child issues. We know child health issues are not limited in one area, but we need a team that can coordinate. We know a lot of things are happening still with pneumonia. Immunization is going on, but still a lot of children are dying of nutrition issues, malnutrition, and then diarrhea. So that coordination is very, very important, and that is going on. We are grateful to our partners. Since we came and then discussed with them, we have developed series of fora where we engage weekly basis, monthly basis, at different levels, and the things have been going on very, very well. For availability of oxygen, we have 11 oxygen plants. We have about 16 districts, but 3 are now functional, and the others will be up and running by the end of December. We are not limited only to the plants, the PSA plants. We also are working with CHI and other partners, UNICEF, and the health system strengthening program to bring in liquid oxygen, which will be in. And as we are doing that, we are actually doing the infrastructural improvements at different levels, at even health facility levels, trying to solarize smaller facilities so that at least the flow of oxygen will be uninterrupted as we go. So at the same time, we know when these oxygen things are there, these are machines, we need the upkeep of them is really, really challenging. So we've actually trained series of technicians to be able to handle these gadgets as they come. But at the same time, as we made a commitment, partners like CHI and others have brought in pulse oximeters, flow meters, you name them, and other accessories, masks, and others. And a huge procurement is still on the way. We believe that by December, when all these partners, the procurements come in, we'll be very strong and well to go. But at the same time, we've already started some quality improvement collaboratives as far as oxygen delivery is concerned. Interestingly, we went forward. We've actually developed the oxygen strategy. What is now left with that we are doing is the protocols as to how to really guide the health facility facility staff in the use of medical oxygen at lower level and even in other areas. So much is happening, and we are delighted with that. And we are very, very grateful that we are being able to do a lot of things. The partner coordination is important. We are working with what we can do. And in the C19 optimization, we've actually put in almost all the other things that other partners are not doing, including the medicines and the others. So we have done that. A lot of them were accepted, some were not, but I'm still in dialogue because since I am the principal recipient, with the country team, we hope that we'll be able to overcome and get almost all the things that we need, you know. So what is now left really is costed so that we can move with it. And what I've asked the program and partners to give me an annual work plan for 2024, and at the same time develop an M&E framework so that we'll be able to monitor or even measure as we go. We will need support for the implementation of the plan. It could be in financial, it could be logistics, as you may need, as I'm saying, or it could be even in human resource. Human resource in which way? We could want consultants in areas where things may be difficult, or we may do some learning, comparative learning issues, like countries where they are doing better in other areas. It doesn't necessarily mean going there, but then now that there are e-learning facilities, we can see how we can really be of help to each other as we go. Advocacy is another, you know, but then the most important thing at global level, what we want global partners to do is we do engage in, internally at local level with our implementing partners, our INGOs, the local NGOs, our bilateral and donor partners in here. But I know at that level, globally, that networking is very, very good. So certain things, you know, every donor has specific ways they do. They have specific things they support. Some will come, we are focusing on water, we are focusing on sanitation, but you look at the child in there. The child needs all of these things. So we are programming the program in such a way that they have to be like the interlocutor between almost all the directorates and the programs, because child survival is not only health related, it has to be multi other areas. So we are actually in dialogue with the Interministerial Council that our minister chairs to really bring in education, to bring in water resources, to bring in environment and other things, which dialogue has already started. It's only one meeting because we know we cannot do it alone. But at international level, within the donor landscape, if we have a strong advocacy for them to understand the linkage for the child, for us to make that impact, we need to ensure that we use every opportunity that can be given from one area to the other. So we are in that. We need the support for that. We know we are medical people. We may not know how to make our business cases. We will need support in making business cases to really ensure that this thing moves as we go. So we are moving. We know it is slightly small, but with the momentum we are seeing, we look a bit happy and we are okay with it. So maybe for now, I will stop there and hand over to you, Lith.
Thank you so much, Dr. Kene. And before we say goodbye to you, we want to acknowledge the strong leadership of your Minister, Austin Demby, in child survival action. He was recently at the WHO Regional Committee in Botswana, where he appealed to other health ministers across Africa to join forces on child survival action. He's written about that. He continues to be one of the strongest voices for action on child survival. So thank you for that. Obviously, he has a great team behind him as well. So thank you, Dr. Kene. We now welcome from Chad, somebody who was with us in Madrid and spoke so powerfully, Dr. Khadija Abgreen from the Chad Ministry of Health. Dr. Khadija.
Ok, merci beaucoup et bonsoir à tout le monde. Je suis très ravie de me retrouver avec vous maintenant, même si c'est virtuellement. Et donc, le Tchad, de par ses engagements que nous avons eu à prendre à Madrid, donc nous avons fait quelques avancées et que nous aimerions bien partager avec vous. Concernant l'engagement concernant la demande d'introduire les vaccins PCV et anti-rotavirus. Donc, par rapport à ça, le pays a validé son plan de rotavirus et le PCV par le comité de coordination interagences. Et nous avons soumis à Gavi ces plans le 4 octobre 2023. Et donc, nous attendons le retour de Gavi. Maintenant, concernant l'acquisition de l'amoxicilline dispersible, oxymètre de peau, etc. Et donc, actuellement, le pays est en train de soumettre au niveau du Fonds mondial, et dans le cadre de ce C19RM. Et donc, nous n'avons pas perdu de vue ces aspects-là. Mais également, l'UNFPA, nos partenaires et l'UNICEF ont déjà commencé à appuyer le pays pour qu'on puisse justement avoir de l'oxygène dont nous avons parlé la dernière fois. Nous avons encore quelques difficultés. Docteur Agré a fait le point lors du forum à Madrid. Maintenant, il y a une chose qui est aussi très importante, que nous sommes en train de faire. Et donc, le pays est en train d'élaborer la prise en charge intégrée des maladies de l'enfant au niveau communautaire. Donc, à partir des documents génériques de l'OMS, nous avons déjà commencé le travail par un comité technique au niveau du ministère avec toutes les parties prenantes, notamment les partenaires. Et donc, ça permettra à l'agent de santé communautaire d'identifier les signes de danger chez l'enfant et de référer l'enfant au centre de santé le plus proche pour vraiment augmenter la survie de l'enfant et qu'on n'aura pas une mortalité qui est élevée. Parce qu'on sait déjà que la pneumonie vient en deuxième position après le paludisme en termes de mortalité infantile ici chez nous au Tchad. Donc, dans ces cas, ici, on a l'hôpital, le centre hospitalier universitaire de la mère et de l'enfant, et l'UNICEF est en train d'appuyer les services de néonatologie et un appareil et extracteur d'oxygène. Donc ça, c'est d'une manière résumée ce que le pays est en train de faire. Donc, on est sur la bonne voie et nous sollicitons en plus encore l'appui de nos partenaires pour que vraiment qu'on puisse augmenter la survie de l'enfant tchadien et qu'on puisse aussi s'aligner avec les autres pays qui ont pris l'engagement concernant la santé infantile. Merci à vous.
Thank you very much. That was Dr. Khadija Abgreen from the Chad Ministry of Health. The ministry came to the forum in Madrid in April with a commitment to introduce PCV and rotavirus vaccines, and that submission has been lodged. They truly delivered on that. Gabby has that application now. The ball is in Gabby's court. The ministry desires to introduce those two vaccines next year, and there are tens of thousands of children who will be alive by 2030 because of those two vaccines as they roll out. So huge progress, and congratulations to the Chad Ministry of Health. We welcome now from Guinea, the Guinea Ministry of Health, someone else who was with us in Madrid and made a huge impression, Dr. Mohamed Lamine Yansane. Welcome back.
Merci Madame pour m'avoir donné la parole pour essayer de faire le point sur le niveau d'avancement des engagements pris par notre pays au niveau de Madrid. Donc, le premier engagement que nous avons pris, c'était l'achèvement de la stratégie nationale de vaccination. Ce processus est aujourd'hui très avancé. Nous avons voulu faire une démarche pas technique, mais collaborative avec l'ensemble de nos partenaires pour que nous puissions avoir des actions mutualisées de chacun de nos partenaires. Donc ça, c'est un dossier qui est très avancé. Nous avons déjà recruté 2 consultants. Les drafts de ces documents existent. Nous sommes donc à la phase d'approbation de cette stratégie nationale de vaccination. Le deuxième engagement sur lequel on s'était engagé, c'était l'introduction des vaccins rotavirus et PCV en 2024. Là également, nous avons commencé cette démarche par voir ceux qui avaient décidé de faire cette introduction en 2023, dont le Tchad, de nous amarrer déjà à ce pays. Et c'est pour cela que nous avons envoyé une équipe en Yamena pour suivre un peu le processus comme ça se fait là-bas. Donc, notre proposition est toujours en cours. C'est l'introduction. Nous la planifions toujours au cours du deuxième trimestre 2024. Donc là, et notre programme élargi de vaccination, mais aussi les différents partenaires de l'Alliance Gavi, travaillent actuellement dans le cadre d'un protocole de recherche pour montrer au groupe technique de coordination sur la vaccination l'importance vraiment d'introduire ces 2 vaccins et de pouvoir montrer ça avec des données réelles pour montrer comment on peut estimer la réduction de cette mortalité avec l'introduction de ces 2 vaccins. Maintenant, pour la réduction des enfants zéro dose qui se chiffrait à près de 200 000 enfants, nous avons vu où se localisent ces enfants, c'est à peu près au niveau de 11 districts de santé. Nous avons reçu un financement de Gavi pour accélérer la vaccination au niveau de ces zones. Ce programme a été officiellement lancé le mois passé. Donc, les activités sont en train de se dérouler et les taux de couverture vaccinale qui étaient aux environs de moins d'1 enfant sur 2 qui étaient vaccinés sont en train de remonter. Selon nos dernières estimations, nous sommes à plus de 55% de taux de couverture vaccinale. Et les dernières campagnes ont surtout ciblé ces enfants zéro dose. Donc, la demande de financement pour Gavi et pour l'introduction des nouveaux vaccins est déjà en cours. Le groupe technique de vaccination prépare les différents dossiers pour qu'on puisse soumettre notre demande d'introduction au niveau de ces vaccins. Un autre de nos engagements, c'était la formation des agents de santé sur la prise en charge de la pneumonie. Ce travail est également avancé et nous abordons cette question avec notre stratégie de santé communautaire où nous avons pu, avec cette nouvelle stratégie, couvrir à peu près 65% de la population rurale par les agents de santé communautaire et des relais communautaires. Ceux-ci doivent travailler sur un paquet d'activités intégrées qui sont aussi préventives, curatives, promotionnelles également. Et dans ce paquet d'activités, la prise en charge de la pneumonie fait partie. Et ces agents ont été formés sur les modules de prise en charge, au moins sur les 60% du pays. Et les médicaments sont fournis par un certain nombre de nos partenaires. Parmi ces partenaires, nous pouvons citer l'USAID qui couvre 4 régions sur 8 au niveau du pays, mais l'UNICEF aussi qui est très actif dans 40 communes de convergence. Et les activités de mobilisation sociale sur les risques de recherche de soins au niveau des maires continuent également à travers nos relais communautaires et nos agents de santé communautaire. Les deux derniers points sur lesquels on a pris des engagements, l'oxymétrie de pouls, nous avons mené donc une étude qui a montré, qui a été très concluante. Donc, la mise à l'échelle de l'oxymétrie de pouls va démarrer dès 2024. Enfin, l'approvisionnement en oxygène, c'est un des sujets sur lesquels nous avons le plus avancé. Et 3 partenaires ont déjà fourni les moyens au gouvernement pour pouvoir assurer la présence de l'oxygène dans tous nos centres hospitaliers. Avec le Fonds mondial dans le cadre du C19RM, nous avons pu acquérir 3 centrales d'oxygène de grande capacité que nous allons mettre au niveau des hôpitaux de région. La Banque mondiale a fourni également 4 centrales d'oxygène de capacité moyenne que nous allons mettre dans des hôpitaux de district. Et l'UNICEF également a prévu la construction de 4 centrales d'oxygène. Donc, c'est à peu près une douzaine de centrales d'oxygène très bien reparties sur l'ensemble du territoire qui vont produire de l'oxygène médical. Et nous pensons qu'avec cette capacité, il y aura de l'oxygène disponible au niveau de toutes les formations sanitaires. Donc, ce sont là les activités sur lesquelles nous avons travaillé depuis Madrid. Ça ne s'est pas fait sans difficulté. Nous avons eu quelques difficultés qu'il faut reconnaître. La première chose, notre pays continue toujours de subir des épidémies multiples et simultanées. Au moment où on vous parle, nous avons à gérer 4-5 épidémies, dont une épidémie de diphtérie, de fièvre jaune également, mais aussi de coqueluche. Et ça ralentit vraiment tout le travail parce que chaque fois qu'il y a l'épidémie, tout le monde se met dans le processus d'éradiquer l'épidémie. Nous sommes également en train de lutter contre l'épidémie de poliomyélite de souche dérivée vaccinale. Et au début du mois, nous allons avoir notre deuxième tour de JNV. La deuxième difficulté, c'est toujours la mobilisation des ressources. Nous avons mobilisé pas mal de ressources, mais les besoins en ressources restent encore. Et enfin, le calendrier sur les exigences de Gavi, nous sommes en train de les remplir. Si nous parvenons à tout ça, j'espère que nous serons dans le bon tempo. Donc, en résumé, la finalisation du plan d'action pour la survie de l'enfant est très avancée. La mobilisation des ressources est en cours et le groupe technique de consultation sur la vaccination est en train de préparer tout ce qu'il faut sur l'introduction des nouveaux vaccins afin de prouver que ces 2 vaccins peuvent réduire très, très considérablement les mortalités des enfants. Je vous remercie de votre très aimable attention. Merci.
Thank you so much, Dr. Mohamed Lamine Yansane from the Guinea Ministry of Health. Extraordinary that amount of progress has been possible given all of the health challenges the country is facing. It sounds like 2024 is going to be a very big year for childhood vaccination in Guinea. Next, we welcome from Somalia, the Somalia Ministry of Health, Dr. Mustafa Awil Jama. Welcome.
Yes, good afternoon, everybody. Good evening, those who are in East Africa. It's my pleasure to attend this second Global Forum for Childhood Pneumonia. The first thing, we in Somalia, what we did about in 2023, the country has developed a community health strategy. That community health strategy basically it is a new strategy in Somalia where female health workers are now allowed, on top of the other activities they do, to also to assess and classify and treat pneumonia, children with pneumonia at the community level, and those who are severely sick or have severe pneumonia to be transferred to the nearest health center. And usually at the community level, these female health workers are taught how to diagnose child with pneumonia. And then they are allowed to dispense and give amoxicillin at community level, at house level, and refer severe cases to the nearest health facility. So far in Somalia, we have 2,000 female health workers providing a community case management of pneumonia, which are operational in Somalia now. These female health workers are supported by the World Bank and other various partners. The plan in the country is to reach these female health workers up to 8,000. And the most important function, they are linkage between the community and the primary health care facilities. The other point is that there was a strong focus on reducing wasting among children. The MOH, with the support of partners, initiated test and scale up simplified cost-effective approaches to address the diagnosis and treatment of acute malnutrition at community level. One of the things which has been done is what they call the IMAMI interventions, whereby it's an intervention where you capitalize what has been in place already, existing system, and then on top of that, you integrate the management of children under 5s, of course, including treatment of acute malnutrition. So also in Somalia, it has been plotted female family MUAC, that is the mid-arm circumference, whereby mothers are put the center of detecting children with acute children with malnutrition, such that they can be referred to prevent severe acute malnutrition or the child getting worse. Mothers are now educated to do MUAC at home. That's what they call the community screening approach that uses the simplified mid-arm circumference. The other important thing is, yes, Somalia has applied the introduction of vaccines. That was the BCV, Rota, and measles rubella vaccine. The good news is that BCV and Rota vaccines have been approved, and the country is planning to start or introduce PCV and Rota next year, hopefully. We will start next year the introduction of PCV and Rota, because Gavi has approved. And we really thank Gavi for the collaboration, and also our partners in the country, WHO, UNICEF, and the Save Children, who really worked with us in developing and working closely as a Somalia country team. However, measles and rubella vaccine was not approved, but however, we will send the proposal on next year, the second 2 weeks of January, and we will be submitting it again. But PCV and Rota has been approved. About the co-waiver, yes, thanks to Gavi again, it has been the waiver has been accepted, as you see, and the vaccines has already been approved, and we are going to integrate with them to our routine immunizations. This will be a huge improvement in reducing under 5 mortalities as you are aware, in Somalia, #1 mortality rate of under 5 children is pneumonia, and it causes a lot of burden to the hospitals and the health system of the country. By introducing PCV, will reduce the burden of the health system, and also it will also reduce the mortality and morbidity of the under 5s. The availability of oxygen, the country has utilized the C19RM, and as you are aware, currently there is a placement of oxygen plants in the referral hospitals across the country. However, there is much needed at district health facility levels, which still does not have the supply of oxygens. There are a number of partners who are currently working with us in terms of acquiring. There is a project of World Bank. There are projects from WHO, which actually are going to cover some of those areas, which are not going to be enough, some regions in the country. In WHO, as we speak, a huge procurement of pulsometer, medical oxygen are on the way to cater around 15 districts in the country. So, however, it's not enough, and that's the area we still need much support in actually availability of this pulsometer, medical oxygen, and also medical supplies that are required to treat patients with severe acute with pneumonia, severe pneumonia. The other important thing is that we in the country we also started we also started other important things. There's also other strategies which are on place, like the reproductive, maternal, neonatal, and child health strategy. That is the RMNCH strategy, which has been developed in the country, and there are very many important interventions that will also mitigate or reduce the mortality of under 5 in our country. We are in process of discussions with the Global Fund for the acquiring the pulsometers and oxygen supplies, and that is still on progress. Thank you.
Thank you so much, Dr. Mustafa Awil Jama from the Somalia Ministry of Health, another ministry that came to the forum in Madrid with a commitment to introduce PCV and Rota virus vaccines. They applied since we met, and it sounds like they've been approved for the PCV and rotavirus component. So those vaccines will roll out next year, a huge milestone, as Dr. Jama said, for children in Somalia. Congratulations to the Ministry of Health and partners. We welcome now Dr. Olusei Omakore from the Nigerian Federal Ministry of Health. They came to the forum with a very ambitious commitment, and we're eager to hear what's been happening in Nigeria. Dr. Omakore.
Good morning, good afternoon, good evening, and thank you for having me.
You're most welcome. Please go ahead.
Now, based on the last pneumonia forum that was held in Madrid, Spain, Nigeria made some commitment, and we've been working absolutely based on that to be able to achieve our desired aim and objective, which is centered towards reducing the high under 5 mortality rate, or especially those that are related to pneumonia. And I will quickly give an overview of the commitment, which is to increase PCV, measles, and DPT vaccines. DPT, you know, DPT comes under the Penta vaccine, above 90%. Then reduce 0 dose of children by 30%. Then increase pneumonia care seeking rate above 40%. And then build capacity of frontline health worker on IMCI pulse oximeter, the use of pulse oximeter, and amoxicillin dispersible tablets. then revise and strengthen national oxygen strategy, and develop a robust child survival action plan as part of Nigeria Third Health Sector Strategy Plan. Implement national pneumonia control strategy and apply to the global fund for pox oximetry, oxygen support, and friendly amoxicillin. So basically, this is what we've been working towards. The direction of the government and the partner, ably led by the Federal Ministry of Health, is actually well captured from this commitment. And if you look at it, as a country, we've been taking track, especially when it comes to the two major vaccines, PCV and Penta vaccines. As you all know, for us to be able to reduce under 5 mortality in Nigeria, we have two, out of the child survival strategies, we have two main important ones that are very dear to us, which is immunization and nutrition. But for the purpose of this meeting is centered on pneumonia. So I'll be talking more about the status of vaccination in Nigeria. For this year alone, as of January, I will be using two sources of data, the DHIS and the mixed survey. The DHIS actually report what happened at the facility level. And for January, what we have concerning PCV vaccine, the pneumococcal conjugate vaccine 3, is that as of January, the proportion of children vaccinated was 76.5. It increases to about 81.9% as at May, and then presently the last data that is available to us for the month of September is 77.8%. For Penta, in which we have the DPT, because Penta vaccine contains 5 different antigens, where we have the DPT, Haemophilus influenza, and hepatitis B. As of January, the value we have, the proportion of children that has been immunized is 75.5%. But here in the month of September, the last data that is available to us, we have 85.7%. Though you can see there has been a progressive increase in the proportion of children that are being immunized, which is aimed at reducing the under 5 mortality rate. Our aim and our target is to make sure that all children in Nigeria are fully immunized from this vaccine preventable diseases. Though with this, we still have some challenges, and most of the challenges are stock out of vaccine. That might have been responsible for us not being able to meet the 100% target. And then the uptake of routine immunization is still suboptimal, probably due to cultural and religious reasons, which the government, the ministry has been working hand in hand with the National Primary Healthcare Development Agency to be able to address that. Then, as we know, we cannot single out pneumonia as a disease, as a single disease entity. There are so many factors which actually affect pneumonia as a disease, and then the overall under 5 mortality in Nigeria, which start from the time of conception to the time of delivery, and as the child is growing. For us, we consider that ANC is very, very key to us, the antenatal care attendance. Presently in Nigeria, the first one is usually very high. We have about 70% of mothers attending the first ANC visit. And we have the strategy we use in Nigeria, we call it the focused antenatal care visit, whereby women attend antenatal at least four times within a pregnancy period. As the pregnancy progresses, the value reduces. Then skill bar attendance, we are still having the value around 51% of most mothers delivering in health facility and being handled by skill bar attendant. Then postnatal care majorly is around 62%, and then BCG being given at the time of the BCG, the vaccine against tuberculosis, about 74% of children are getting it. These data are actually coming from the mix. The mix of it is usually conducted every 2 years in Nigeria. And then for penta vaccine, which is one of the key vaccines for pneumonia, penta 1, which is the first penta, where we have the DPT, about 70% of children, the value data available to us shows that 70% of children are taking penta 1. But that also, there's attrition as the child ages. So for penta 3, what we have, the number of children, the proportion of children that have taken penta 3 is 57%. Then overall, the proportion of children in Nigeria that are fully immunized is 36%. So this value is very low, but there has been a progressive improvement, and that's what we aim to achieve with all our strategies that have been put in place. So now, getting vaccine apart, for children that are having presenting with symptoms.
Dr. Omakore, just 2 minutes left.
Okay, for children that are presenting with for children that are presenting at the facility, we can see that about 62% of them come with fever, and then the remaining 39% have ARI and diarrhea. And we are also seeing a progressive increase in the number of children that are getting presenting in the facility as a result of sickness and when they are related to pneumonia. So Federal Ministry of Health has been working with MPCD, the primary health care, to leverage on community structure using an integrated approach to be able to create awareness for pneumonia control and then preventing it. Then in terms of oxygen, we have a roadmap on oxygen which align with national guidelines and strategy such as pneumonia control as well as IMCI strategy. The roadmap recognizes pneumonia as the leading cause of death in children among children under the age of 5, and is responsible for about 14%. So following the launch of this strategy by the Honorable Minister, the Ministry has been able to disseminate this document so that people at the lower level will be able to know what the government is doing and how to handle things that are related to pneumonia. Then we've been able to train frontline health workers on hypoxemia management and pneumonia treatment in Nigeria. And then for quality improvement, the ministry has been able to incorporate pulse oximetry use as a diagnosis tool into the IMCI strategy. IMCI has been a policy thrust for government to reduce under 5 mortality in Nigeria. And FMOH, in partnership with UNICEF, we've been able to train about 3,000 frontline health workers at PhD and secondary level on IMCI and then pneumonia treatment algorithm. Concerning the national...
Dr. Omakore, I'm sorry, but the time is almost up.
Okay, thank you for having me. Thank you.
Sorry to cut you short. Obviously, Nigeria is a very big country with lots of things happening. We thank you for that update, and exciting to see a child survival action plan will be coming from Nigeria, similar to Sierra Leone. We also note many of us are very excited to be working with your new Federal Minister for Health, Dr. Mohamed Pate. We know he has a deep commitment to child health and will be a strong leader for children. So looking forward to more from Nigeria. For our final update from our government colleagues, we welcome Dr. Valerie Zombre from the Burkina Faso Ministry of Health.
Merci pour la parole. C'est vraiment un honneur pour moi de faire sur cette communication sur le suivi des engagements pris par mon pays lors du 2e forum. Donc, pour ce qui concerne le premier engagement qui portait sur la mise en œuvre d'une stratégie qui vise à garantir la disponibilité d'oxymètres de pouls dans les établissements de santé, qu'est-ce que nous avons pu faire? Au niveau du pays, nous avons élaboré un plan d'approvisionnement en oxymètres de pouls pour faciliter en tout cas le diagnostic précoce de la détresse respiratoire. Et il faut dire que ce plan était assorti d'un coût, ce qui nous permet de faire vraiment un plaidoyer pour rendre disponible l'oxymètre de pouls dans nos formations sanitaires. Et nous avons pu rendre disponibles ces oxymètres de pouls au niveau de 2 districts sur les 70 et dans un centre hospitalier régional. Donc, en perspective, pour ce qui concerne cet engagement, c'est vraiment, nous allons rendre disponible l'oxymètre dans les autres formations sanitaires de la région où nous avons utilisé l'oxymètre de pouls en phase pilote, mais également aussi, nous sommes en train, en tout cas, de mettre l'oxymètre de pouls au niveau de 3 districts dans 3 régions qui sont les Hauts-Bassins, la région du centre et du centre-sud au niveau communautaire. Notre deuxième engagement portait sur la mise en œuvre aussi d'une stratégie pour nous permettre d'accélérer la construction d'usines d'oxygène médical dans les hôpitaux. Qu'est-ce que nous avons pu réaliser concernant cet engagement? Nous avons pu rendre disponibles en tout cas des centrales d'oxygène au niveau de 4 hôpitaux, donc un hôpital hospitalier universitaire et également 4 au niveau régional. Et nous sommes en cours en train de rendre disponibles les centrales d'oxygène dans 3 hôpitaux universitaires et 3 hôpitaux régionaux, ce qui va nous amener à autour de 11 structures avec oxygène. Nous avons entrepris des activités de maintenance pour ce qui concerne les hôpitaux qui sont équipés. Donc, c'est la maintenance et également aussi des pièces de rechange pour ces structures qui sont équipées. Donc, en perspective, il faut dire que nous sommes actuellement en train de finaliser notre plan triennal pour renforcer la disponibilité et l'utilisation de l'oxygène médical au niveau de nos formations sanitaires, et ce plan va couvrir la période 2024-2026. Et également aussi, nous sommes en train de faire l'implémentation et l'approvisionnement aussi de l'oxygène au niveau de nos centres médicaux avec interne chirurgicale, qui sont des centres qui se retrouvent au niveau des districts et qui permettent de faire les interventions au niveau de ces structures. Notre troisième engagement, c'était vraiment sur la disponibilité des médicaments essentiels pour traiter la pneumonie ou autres affections respiratoires et mettre en œuvre des stratégies innovantes. Donc, qu'est-ce que nous avons pu faire? Il faut dire que nous avons rendu disponible l'amoxicilline dispersible au niveau vraiment de notre centrale d'achat, et à travers cette centrale d'achat, les formations sanitaires peuvent se ravitailler pour, en tout cas, prendre en charge la pneumonie. Nous avons également élaboré un plan de distribution de médicaments au dernier kilomètre. Il faut le rappeler, depuis un certain temps, notre pays est en tout cas confronté à une situation sécuritaire, et ça fait que la distribution de médicaments au dernier kilomètre constitue un problème. Donc, il fallait vraiment un plan pour faciliter la distribution de ces médicaments au niveau du dernier kilomètre. Et il faut le dire aussi, pour ce qui concerne la prise en charge intégrée des maladies de l'enfant, y compris la pneumonie, avec le registre électronique de consultation, nous étions à une couverture de 9 et nous sommes en train de faire l'extension à une région, ce qui va nous amener à une couverture de 10 régions sur les 13, et ça va nous permettre d'améliorer la qualité de la prise en charge de ces maladies chez les enfants. Nous avons mis en phase pilote ce qu'on appelle l'administration prophylactique de masse de l'azithromycine chez les enfants de 0 à 11 mois dans 13 régions, puisque l'un des objectifs de cette administration prophylactique, c'est vraiment réduire les infections chez les nourrissons, y compris la pneumonie. Et en perspective, nous allons étendre cette stratégie innovante en 2024 dans 3 autres régions qui sont la région du centre-ouest, centre-sud et les Cascades. Et également aussi, nous sommes en train de faire, grâce au fonds en tout cas de la Banque mondiale, l'extension aussi de la stratégie intégrée de prise en charge des maladies de l'enfant avec le registre électronique de consultation dans les 3 autres régions qui nous restent, donc c'est les Cascades, la région du Centre-Sud et les régions du Centre. Et notre 4e engagement portait vraiment sur la poursuite de la mise en œuvre de la stratégie de santé communautaire pour couvrir les zones à déficit sécuritaire. Et en termes de progrès, qu'est-ce que nous avons fait? Le gouvernement a pu recruter 15 000 agents de santé à base communautaire pour pouvoir couvrir les zones périurbaines et les zones urbaines de 2 grandes villes de notre pays qui sont Ouagadougou et Bobo-Dioulasso, mais également aussi pour 5 régions à fort défi sécuritaire, et ce qui nous amène à une couverture vraiment de 95% de agents de santé à base communautaire qui peuvent nous aider à prendre en charge nos enfants au niveau communautaire, mais également aussi à fournir des informations pour améliorer la survie de ces enfants-là. Et ce qui concerne la mise en œuvre...
Excuse me, Dr. Zombre, just 1 minute to go. Thank you.
Oui, j'ai bientôt fini. Donc, je disais aussi que nous avons procédé à la digitalisation de nos modules de formation pour ce qui concerne le niveau communautaire. Donc, dans le domaine du plaidoyer, il faut dire que notre gouvernement va poursuivre son plaidoyer afin d'assurer l'acquisition des équipements essentiels pour assurer la survie de l'enfant et également aussi poursuivre le plaidoyer pour combler les lacunes dans le domaine de l'opérationnalisation de la couverture sanitaire universitaire et universelle. Et il faut dire que pour ce qui concerne en tout cas la survie de l'enfant au niveau du Burkina, c'est une priorité et ça figure au niveau de notre document de politique pour ce qui concerne la santé. Je vous remercie pour la parole.
Thank you so much, Dr. Zombre, Valerie Zombre from the Burkina Faso Ministry of Health. That ends our round of updates from our Ministry of Health colleagues. We turn now to some of the international organisations who made commitments, and delighted to kick off with Dr. Ephraim Lamungo from UNICEF.
Can you hear me, Liz? Good morning, good afternoon, colleagues.
Yes, go ahead.
Perfect. Thank you so much. And I would like to start by appreciating the partners for convening this meeting, and most importantly, Liz and her team from Every Breast Count Coalition for bringing us back together to follow on some of the commitments we have made on the second Global Forum on Childhood Pneumonia back in Madrid. I would like to also appreciate and send my sincere appreciation to the countries who have earlier presented their progress made based on the commitment they have entered 6 months back. It is very tremendous and incredible progress that has been made. And we as partners do have the responsibility to be able to support these countries to realize these commitments become true. But the leadership and the importance of country leadership has really been demonstrated by the progress made based on the reports presented earlier. So I'm very delighted to join this session that discusses the progress made on these commitments. As most of you know, UNICEF in the second Global Forum made a commitment to be able to support countries to deliver on 3 important promises. Number 1 was our commitment to the Agenda of Child Survival Action Initiative, and we had committed to support countries to strengthen their community health systems, primary health care being the main entry point, and with an emphasis on high burden countries, particularly countries in the West and Central Africa region, but also a focus on the East and Southern Africa region. Secondly, we commit to strengthen immunization and vaccination programs, which is an opportunity to reach children that are missed, and mainly the zero-dose children that we usually miss if are in missed communities. And this was heavily emphasized with our focus on the big catch-up, which is an effort to be able to catch up on children that were missed during the pandemic years, mainly children missed from 2019, 2020, 21, and 22. And an effort to really be able to restore vaccination services disrupted due to the pandemic, and above all, strengthen immunization program. The third commitment we had was sustaining support to scaling up access to oxygen and pulse oximetry, with an emphasis on supporting countries to have the required facility, infrastructure, and policy landscape to be able to build and roll out this important infrastructure. And I'm very delighted to report on some of the tremendous progress made from our side, working with our partner countries who are on the leadership role to be able to drive these commitments. 2 months ago, UNICEF joined hands with several other partners, notably USAID, the World Health Organization, and the Global Health Initiatives such as Global Financing Facility, the Global Alliance for a Vaccine, and the Global Fund, along with several other partners, to launch its Community Health Delivery Partnership, which is a new and reignited partnership to be able to pull in resources together and commitments together in support of countries' interest to build strong community health worker programs. The overall intention of this partnership, as it has been alluded to by some of the intervention made by, for example, Dr. Sarti from Sierra Leone, who underlined the importance of coming together and coordinating partners. We organized this partnership and launched this partnership with an intention of supporting countries to have community health workers that are skilled, supervised and supported, and most importantly, paid community health workers that will serve as the anchor of the primary health care program. In this launch, we have committed to support 25 countries, and the countries who are taking part in this meeting are also some of those who are member of these 25 priority countries for the extended support by partners. So UNICEF will work with USAID and other partners that I have mentioned earlier in developing policies and strategies, and most importantly, bringing in different funding sources under the leadership of countries to support firm and a strong community health worker program going forward. Upon strengthening vaccination, one of the things that we had committed on is implementing the big catch-up. We estimate about 80 million children have been missed or have not completed their vaccination due to disruptions caused by the pandemic, and we're not able to catch up the disruptions, those children that were actually missed. And all partners came together, including Gavi, WHO, UNICEF, and several other partners, to launch the big catch-up along with the release of the State of the World Children report by UNICEF earlier this year. And based on that commitment, and the commitment to reach these children, which we have seen increasing number of outbreaks in several countries, and some of the outbreaks earlier alluded by Dr. Lamine from Guinea, the likes of the multiple outbreaks happening in countries, and even to mention measles outbreak that has currently about 37 countries that are currently reporting on large and disruptive measles outbreaks happening, does really show the increasing immunity gap that needs to be filled very urgently. So based on this commitment, the partners of the Global Alliance for Vaccine, Gavi, have been able to agree on availing additional vaccine doses to countries who have committed to conduct their big catch-up campaigns over the next 2 years period. There has been challenge about finding co-financing for these vaccine doses. While pending the approval by the board of the alliance, countries can expect to receive funded doses without the need to pay for co-financing after the approval of the board of the 2 or 3 weeks period. So this is a wonderful news, given that it offers countries the opportunity to not only provide the regular vaccines, but also the expensive vaccines, the likes of PCV and rotavirus vaccines, as part of their big catch-up. The third and the most important is our effort in sustaining support to scaling up access to oxygen and pulse oximetry. And as some of you may already know, UNICEF has already been supporting, and we have heard feedback from countries, been supporting 50 countries to scale up access to oxygen, including the deployment and installation of about 140 oxygen plants to ensure sustainable readiness of countries to be able to provide access to oxygen and pulse oximetry. We have also focused on strengthening capacity of health workers to be able to identify and treat children with pneumonia as part of our strengthening community health workers effort. Earlier, some of the countries mentioned about importance of solarization. UNICEF has a plan to support over 1,000 health facilities across several countries with solarization of health facilities, not only for vaccination, but also for the broader primary healthcare interventions. And this is part of a broader plan whereby over the next 5 years, we intend to work with countries and partners to solarize 30,000 health facilities across different priority countries, in which most of them are challenged by pneumonia, and there is a need to strengthen systems along this.
Dr. Ephraim, your time
Yes.
is almost up, Dr. Ephraim.
You said what? Sorry.
Your time is almost up. I'm just giving you the time call.
All right, just to conclude. And as commented earlier, UNICEF will continue its support to countries in planning, procurement, and implementing and operationalization of these oxygen plans, and most importantly, improving access to oxygen. I would like to close by clearly stating the importance of recognizing and acknowledging the unfinished business. Globally, especially in the African continent, the overall coverage of PCV vaccination is just 64%. And this is the third dose of PCV vaccine. And the target is to get to 90% by 2030. So there is a need to really intensify our efforts, including the support to the 4 countries who have taken a very courageous step forward to send applications to Gavi, and Somalia being approved at this very moment. Will continue our support to this. As global partners, we call on the strengths of countries and partners to be able to reach children missed from vaccination, and most importantly, commit our efforts until the 700,000 children that are annually whose lives are lost to pneumonia, until that becomes history. Thank you very much. Back to you.
Thank you so much, Dr. Ephraim Lamango from UNICEF. Always a call to action from Dr. Ephraim, and that was a powerful one. Thank you. We're going to ask our speakers to be as brief as they can so we can make sure we have time for everyone to speak. We've got some great comments in the chat. Laura Shimp from JSI is putting some provocative questions in there. Please use the chat that way. We love it when people converse in the chat. Now we call Dr. Amy Latrielle from Gavi.
Thank you so much. Can you hear me, Leith?
Yes.
Wonderful. It's a great honor to be here with esteemed ministries of health, alliance partners, and certainly the global community committed to combating childhood pneumonia. I am here to state that Gavi reaffirms its commitment to supporting countries to introduce, finance, and equitably scale up coverage of pneumonia-fighting vaccines, including PCV, and to work with manufacturers to support equitable and sustainable PCV supply. Between 2009 and 2022, Gavi's supported PCV programs reached approximately 372 million children and helped avert more than 1 million deaths. Gavi's support for PCV is one of the organization's largest by cost and impact. So more specifically, Gavi commits to providing technical assistance, flexible funding to support one-off vaccine introduction costs, and vaccine catalytic financing, among other tools to drive sustainable and equitable introduction of PCV in both former and never Gavi eligible countries. Secondly, we're working with alliance partners, countries, and private sector to foster sustainable, healthy markets and raise awareness on new vaccine options so countries can make informed decisions to continue benefiting from innovations in pneumonia-fighting vaccines at affordable prices offered through Gavi support. Working with key partners, including civil society, to build political will and strengthen countries' prioritization of pneumonia-fighting vaccines appropriate to their contexts, and to ensure the sustainability and equitable introduction and scale-up of PCV as part of national routine immunization programs. Also, in exceptional circumstances, considering annual co-financing waivers for PCV introduction upon a country's formal request at the time of application, and in line with the recent approved board decision and criteria on co-financing flexibilities, temporary waivers will be considered only for fragile and conflict-affected countries that have been experiencing large-scale humanitarian crises for at least 4 consecutive years. And to the extent that the crisis profoundly hampers government's ability to meet the co-financing requirement, these will be considered. The annual waivers will be subject to an assessment undertaken with relevant partners of the exceptionality and severity of circumstances and its impact on the country's ability to co-finance and its capacity to effectively launch and sustainably roll out new vaccine programs. And we've seen this with some of the countries that are now introducing within the fragile and conflict segment. Gavi's support project progress is tracking well, thanks to the political commitment and financial commitments from governments, as well as supportive advocacy from international partners and CSOs, such as Save the Children. Gavi has actively coordinated information exchanges between country EPI, alliance partners, and the private sector to ensure that alignment between country plans, supply availability, and partners' readiness to support implementation. We've also worked alongside Foundation Miro, Save the Children, WHO, and UNICEF to bring together countries, partners, and experts in Chad in September to review progress and work throughout the application completion. And a result of this great collaboration happened this week with last week, Gavi's independent review committee approving Somalia's Ministry of Health request, which we heard about earlier, for PCV and rotavirus introduction support. We're really excited about this and look forward to that introduction in 2024. So in the interest of time, I thank everyone again, and to all colleagues and partners for your dedication to working on this worthwhile endeavor and for your commitments to reduce pneumonia globally. Back to you.
Thank you so much, Dr. Amy Latrielle from Gavi, such a critical vaccine partner for the countries here today, but many more. And just a huge kudos to the Gavi team for being so flexible in in working with countries that are fragile in conflict and affected to make sure their children don't miss out on these most life-saving vaccines. So big cheers for Gavi. Dr. Keith Klugman from the Bill and Melinda Gates Foundation.
Thanks, Leith, and thanks everybody. It's a great pleasure for me to be here today to follow up on our commitment made at the meeting in Madrid. I'm actually in Durban in South Africa, where it's nighttime already, and there'll be tomorrow starting the big World Society of Pediatric Infectious Diseases meeting. So the Gates Foundation is the largest foundation investing in pneumonia prevention, and as such, we have an enormous commitment, but also responsibility to do this as well as we possibly can. So we made a commitment of $200 million in grant funding over the next 18 months, and we are on track to meet that commitment. So how do we do it? How do we decide where to spend money on pneumonia prevention? As you all have mentioned, pneumonia is a major cause of child mortality. And so we spend money to decide which are the major causes of pneumonia, which vaccines could be developed. And it would not surprise you to know that the pneumococcus is the leading cause of pneumonia mortality in children. And as such, in that area, we helped to fund the development of the first PCV made specifically for developing countries. And in addition, we are now working on next generation PCV product. The reason for this is that we are aware from studies, including a study called CHAMPS, which we're funding throughout Africa and parts of Asia, that the pneumococcus, even after the introduction of 10 to 13 valent vaccine, is a major cause of pneumonia mortality. So working on the development of next generation 20+ valent vaccines, and then also working to make sure these vaccines become available through Gavi. The second major cause of pneumonia for which we have never had a vaccine is RSV. So RSV stands for respiratory syncytial virus, and RSV is a major cause of pneumonia mortality. Our data from which Leith has just suggested, you all look at the data, show that children who die in the first 6 months of the week have a 10% chance of dying with RSV in their nose. And so there's been major advances in RSV. There is a monoclonal antibody, which is available at the moment only in rich countries, but we at the Gates Foundation are funding through the Gates Medical Research Institute a monoclonal antibody which will be affordable for Gavi-eligible countries. This is now going through the process of licensure, and we're looking for a partner. In addition, there is a new vaccine given to pregnant women to protect against RSV. It has been licensed again in rich countries. We have funded the manufacturer to make a multi-dose vial, and we are looking forward to the vaccine rolling out quickly in poor countries. I again see from the chat comments about Sierra Leone. I was in Sierra Leone just 3 weeks ago and want to commend Sierra Leone for the efforts they are making to reduce childhood mortality. We were in remote parts of Sierra Leone where the CHAMPS is cited. After RSV, the major cause of mortality, at least 100,000 deaths associated with very young children, the first day of life, and also with stillbirths, is a bacterium called GBS, Group B Streptococcus. And we are working with the manufacturer of the first Group B Streptococcus vaccine to again fund the development of the vaccine and make it available through Gavi. Just two more things I want to mention. One is that antimicrobial resistance is an increasing problem, and many babies who are born prematurely are affected by resistant bacteria, including Klebsiella. So we are looking to see if a Klebsiella vaccine is possible. Most of the bacteria that cause pneumonia also cause meningitis, and we are very strongly supporting WHO in their efforts to produce a roadmap for the prevention of meningitis by 2030. The roadmap includes the prevention of epidemic meningitis by 2030 and reduction in mortality from meningitis by 50%. So we are very excited in that area too to be funding a next generation 5-valent conjugate vaccine specifically designed for the meningitis belt, which is countries in sub-Saharan Africa. Finally, then, I just want to say that we are delighted with the progress that is taking place. There will be more done to prevent pneumonia deaths in the next year in 2040 than ever before, with the continued rollout of existing vaccines, and then hopefully the rollout of new vaccines to prevent pneumonia. And the Gates Foundation continues to be committed to reducing mortality from pneumonia. Thank you very much.
Thank you so much, Dr. Keith Klugman from the Gates Foundation. A rich pipeline of vaccines coming, which will only help us drive pneumonia deaths down further. Really excited about the RSV vaccine, particularly because it does help children under 6 months, where we know a lot of the pneumonia deaths cluster now amongst the little ones. And this, as well as the Group B strep, is really going to help that population of very young, vulnerable babies. So thank you so much for that excellent, and it actually leaves us very optimistic, Dr. Klugman, about the potential role of more vaccines in reducing pneumonia. Now we come to our NGO, our second last update, and we selected this one because I think Save the Children win the award for registering the most commitments in Madrid. But here we've asked Eric Swedberg from Save the Children to come together with partners Jody Allison from MAP International and Dr. Barry Finette from ThinkMD to talk about 2 commitments. I think there are even more than 2 that you registered at in Madrid. So Eric, welcome.
Thank you, Lee. It's an honor to be part of the Progress Roundtable today. And Save the Children takes this opportunity to strongly reaffirm our commitment to work with governments and global, regional, national, and local partners for accelerated implementation of child survival efforts, and to contribute to saving the lives of millions of under 5 children, focusing special attention on the 54 off-track countries and prioritizing actions in communities that are most affected by crisis and conflict. So we're doing this by a lot of advocacy for reforms and supporting the development and implementation of integrated child survival strategies, and by mobilizing and engaging communities for locally led actions to elevate the voices of children and families for inclusive solutions. we're committed to making long-lasting and sustainable change for the health and well-being of children. So this will only be achieved by working together to integrate services that provide a more comprehensive approach for children, their families, and their communities, and ensuring a healthy start in life for all. So during the second Global Forum on Childhood Pneumonia, Save the Children made a commitment with ThinkMD to support adoption and scaling up of clinical intelligence and data analytics platforms to improve the health of children. To fulfill this commitment, Save the Children is partnering with ThinkMD and the Ministry of Public Health, Population, and Social Affairs in Niger to introduce a digital application. We're planning to introduce it in 125 health centers in 9 districts of the Maradi, Tillabéri, and Zinder regions. And ThinkMD's application will be adapted to Niger's national guidelines. So we're in advanced discussions with the Ministry of Health in terms of implementing this work. And under this project, we're working through USAID's Kulawa project. Health workers will be using these digital tablets to provide IMNCI consultations to children, and will feed that data into the national DHIS2 system. And we're also actively exploring the introduction of the ThinkMD platform in other countries. So we're having discussions with colleagues in Sierra Leone and in Zambia for the potential introduction of the platform in the coming year. So Dr. Barry Finette is on the call, and he will be speaking a little more to that commitment. But before going to Barry, I'd like to also talk about the second commitment that we made in collaboration with MAP International. Save the Children and MAP International are partnering to strengthen the availability of life-saving antibiotics and ORS for community-based management of pneumonia and diarrhea of under 5 children in Somalia. So MAP will be providing 200,000 patient treatments of amoxicillin and 25,000 ORS sachets to treat children diagnosed with pneumonia and diarrhea. And we're doing this through that network of community health workers that we heard about earlier in Somalia, the female health workers under the integrated community case management of childhood illness strategy. And we're going to be working in 2 areas of Somalia, Gabile and Beledweyne areas, where these commodities will be provided to families free of cost. So I'd like to ask Dr. Barry Finette to make some remarks, and after him, Jody Allison will also talk about our partnership with MAP.
And just one minute each. Barry and Jody, just 1 minute each.
Thank you so much, Eric, and thank you everybody who is participating in the forum. It's a great honor. Eric has described a lot of the work and partnerships ThinkMD has been developing with Save the Children and some of our future plans. We're extremely excited about the expansion of the use of our machine-based learning clinical decision support tool and data analytics platforms. Just to put some scope into it, our platform has been used in over 11 countries, facilitating over 1.5 million encounters. We've worked on assessing children. It's focused on children under 5. It is a completely compliant IMCI guidelines. And with the work with Save the Children and others, we've identified over 55,000 children who have a risk of possible pneumonia, over 6,000 with a severe risk of pneumonia. And of interest, we've been able to also demonstrate some comorbidity association with these young children, including the fact that over 30% of them also have evidence of malnutrition, which is obviously a very important risk factor. And some of the work that we've done with Save the Children in Nairobi and other countries have been able to show that the utilization of the technology can increase IMCI compliance by over 200%. We can increase the number of danger signs that are being acquired by the community healthcare workers. We increase use of amoxicillin DT versus other antibiotics, as well as demonstrating an improved knowledge base of when to use antibiotics and when not to use them through the use of the technology. And we look forward to expanding this work with Save the Children in Niger and other countries, as Eric outlined. Thank you, Leif.
Thank you. That's Dr. Barry Finette from ThinkMD. I dropped the link into the chat. They have a beautiful website. Go explore. Jody Allison, MAP International. Welcome, Jody.
Thank you, Leith, and thank you, Eric. You've really summarized our commitment perfectly. Thanks for everyone for having us here. We love being at the table. Our achievement so far is that we've spent the first 6 months really establishing the relationship, best practices, and expectations between all partners involved to ensure seamless implementation. We have 50,000 treatments of amoxicillin, over 1/4 of our total commitment, that's staged and ready to go, and 150,000 treatments of amoxicillin for this commitment that are already in production to ensure that there's going to be no gaps in programming once the product distribution starts. Here's what we're going to be doing soon. We're really excited about a successful implementation of the first 6 months provision of medicine, and then we will identify any barriers and adapt quickly. We're also going to further look into options for oral rehydration solutions, as the original product intended for this pilot can't be used, but we have really prioritized the amoxicillin over the ORS, but we're going to get there. And what's next also for all of you is that we want you to be part of our scaling and replication of this opportunity. So we want to connect with members of this coalition who can help support the FR efforts for further implementation. We want to give special thanks to Dr. Bube and Dr. Sheetal for their efforts in this commitment. And then for many of you, we want to reach out to you and connect with you in the new year. We love the commitment that everyone has toward prevention and vaccination, but we also feel this huge urgency to help children that get pneumonia in the meantime. So anticipate us reaching out to you. I'm going to put my email in the chat so you can reach out to us if you are excited, like we are, to be part of this commitment that we have made. Thanks.
Thank you, Jody Allison. What a lovely offer. Please take her up on that. And I want to also acknowledge Jody's colleague, Brooke Allison, who's an integral part of the MAP team on this commitment. So if you like what they did with Save the Children, it sounds like they have appetite for more. Let's move now, thank you, Jody, to our last commitment update before we move to closing remarks. We had many companies come to Madrid and they made commitments, but this one wowed everyone. Dr. Bernard Alayo from Huatele.
Thank you, Leith, and thank you everyone for the opportunity to be back here again. One would wonder whether it still makes sense to continue working on oxygen production, given the large amounts of donations that happened to countries during COVID-19 pandemic. The answer is lies in the fact that actually PSA plants are very difficult to use. And in our assessments, and based on what we have used in the past, the utilization will be challenged because of maintenance issues. As a result, we committed in Madrid to work on changing our main production system based here in Kenya from PSA to liquid oxygen. And I'm glad to provide an update today that we have closed a raise of $20 million and have started the process of construction of Kenya's and East Africa's largest liquid oxygen plant that will be set up out of Nairobi at a place called Tatu City. We have received this funding from Soros Economic Development Fund, FinFund, DFC, GCC Canada, and UBS Optimus Foundation. It's a mix of debt and equity in equal proportions. To move forward, we will be working very closely with our partners who are on this call, Air Liquide, on providing the technical assistance, since they have a lot more experience with locks, and we want to appreciate their support. We expect that this plant will be ready in another 14 months or so and providing oxygen to hospitals. What is the remaining challenge once we get this plant working? I think the main challenge is how the poor pay for oxygen. We will make sure that the production and the product is there, but we need to develop solutions for making this product available to poor facilities, particularly in remote locations where oxygen providers typically avoid going to. Secondly, we are working with many partners to develop newer ways of bringing liquid oxygen to primary care facilities with smaller cryotanks, since liquid oxygen is really cheaper, and if you can bring it to lower level facilities, you don't have too many moving parts. So it will be a much better solution if we can bring it down there. So those would be the two pending issues that we are working on with different more business models going forward. We want to thank everyone that have supported us so far and really appreciate, Leith, your personal efforts in putting this team together. And we look forward to future collaborations with you all. Thank you.
Thank you, Dr. Bernard Alayo from Huatele. Please, if you haven't seen the announcement of the investment in what's been a vision for Dr. Alayo for many, many, many years, he's worked tirelessly on this against enormous odds. So congratulations, Bernard, to you and all the people around you who support you and believe in what you're trying to do for East Africa. So that ends our updates, and we have about 15 minutes more in the program, so please stay with us. We move now to closing remarks, and it's a special pleasure always to introduce Her Royal Highness Infanta Cristina of Spain. She has leadership roles with La Caixa Foundation and IS Global, but really, she has been a powerful voice for child health for more than 2 decades, and childhood pneumonia particularly. She was co-host of the wonderful Madrid Forum, and we've invited her to provide some closing remarks for us. After she speaks, we have a beautiful video to show you, so please stay with us, and then I'm going to come back and just give you a round of next steps, really. So don't leave us, stick with us until after the video, but let's hear now from Infanta Cristina.
Thank you, Leith. Thank you very much for your kind words. Good morning and good afternoon, good evening to everybody. For me, it is a great pleasure to close this very interesting commitment progress roundtable following up on the second Global Forum on Childhood Pneumonia held in Madrid in April this year. Firstly, let me thank all the speakers and also congratulate you for your work and willingness to meet the commitments your governments and organizations made at the forum. We have heard here great and amazing progress. Congratulations to all of you. Secondly, special thanks to Leith and all those involved in organizing the session for reminding us that we made commitments and for encouraging and kindly pushing us to meet them so that we can come as close as possible to achieve SDG 3 by 2030. Leith, your leadership here is pivotal, so thank you very much indeed. As most of you know, La Caixa Foundation has been committed to global health since the inception of its international cooperation program back in 1997. The focus has always been placed on poverty-related diseases to try to precisely break the vicious circle of poverty and disease. Therefore, all over these years, the foundation has partnered with key global health actors in several projects to fight pneumonia, malaria, malnutrition, and to boost immunization, among others. In Madrid, we committed to 1, continue with our support to Gavi to prevent pneumonia with PCV vaccination, especially in Mozambique and Ethiopia. 2, mobilizing support from private banking customers, employees of CaixaBank Group, individuals, and Spanish companies as part of a business alliance for child vaccination. And 3, keep including the fight against pneumonia as a priority in global health programs that we promote in the countries where we are implementing projects. Well, since then, we have renewed our partnership with Gavi for PCV in Ethiopia and Mozambique, and funds raised will continue to be matched by the Bill and Melinda Gates Foundation through the Gavi Matching Fund initiative, thus quadrupling the overall impact. It is worth noting that since 2019, La Caixa Foundation's funds have contributed to purchase the pneumococcal vaccine in Mozambique and Ethiopia, sponsoring 100% of disbursements of Mozambique, 80% in 2018, and 25% of disbursements to Pneumo Ethiopia for the year 2021 and 2022. And since the beginning of this partnership back in 2008 to October 2023, the foundation has raised 15.2 million euros from donations, 29 million euros from La Caixa Foundation itself, making a total of 44.2 million euros that have been matched by the Bill and Melinda Gates Foundation. All these funds have contributed to vaccinate almost 9 million children. Also, we are currently working on a new global health strategy with focus on programs more closely linked to child survival. In 2015, the world set its most ambitious child survival goal for every country to reduce child deaths to at least 25 for every 1,000 children born. Now we find ourselves with just 7 full years left to achieve it, the halfway mark of the Sustainable Development Goals. After a punishing pandemic that affected every country, it is not a surprise that many countries are not on track to achieve the goal. 54 countries, almost 1 in 3, will not make the child survival SDG by 2030 at current rates of progress. 3 in 4 of these countries are in Africa. In most of these countries, child deaths are concentrated in the post-neonatal period, among them babies aged 1 to 59 months. And the leading causes of post-neonatal deaths should be familiar to us all by now: pneumonia, malaria, and diarrhea. In addition to these direct causes of child death, there are many risk factors, chief among them malnutrition, unsafe water, and poor sanitation. Children need rapid increases in protection with the vaccines that target pneumonia, malaria, and diarrhea, especially with PCV, rotavirus, measles, DTP, and the new malaria vaccine. And when children get sick, they also need immediate access to medicines like amoxicillin, artemisinin-based combinatory therapy, oral rehydration salts, and zinc. When healthcare is delivered close to home by trained health workers equipped with these vaccines and medicines, dramatic reductions in child death are achievable. Reaching the populations of children at greater risk of death first, that it is the fastest way to save lives. And we need to get much better at identifying these children and protecting them. The new global zero-dose vaccine effort is a great example of this. What I've described is being called the renewed Child Survival Action Agenda. And I'm excited about this new movement that asks all of us to join forces to reach out to all these children. We all know very well that children are the future and that we need to protect them. It is our responsibility and it is our moral duty not to fail them. You can certainly count on La Caixa Foundation to stand with all of you to do what we can mostly do to achieve our promise to the world's children. And as Leith has told us just a couple of minutes ago, to conclude and to inspire us all to work harder together, a short video of child survival action will be shown to end this roundtable. Thank you very much.
Child survival is about giving every family, every mother, a chance to come home at the end of a long day and have the pleasure of interacting with their child.
The survival of the child is like the survival of the community.
Since the beginning of this century, we've managed to make incredible strides in reducing child mortality, but we've only gotten halfway. And with COVID, things started going backward.
The world is losing an entire generation by allowing children to continue to die of pneumonia, malaria, and diarrhea. And you also realize for us in Africa, it is extremely important because it is also tied to socio-economic development. It is first and foremost a human rights issue. Secondly, it's a moral and ethical issue.
We have the evidence that shows which interventions save lives, and together we have the technical expertise, we have the resources, and most of all, we have the commitment to end these preventable deaths. The time is now.
Parce que nous savons que le taux de décès au niveau des enfants est très élevé. Or, c'est des décès évitables.
While it's ambitious, it is doable. It is urgent for all of us, country governments in the lead, partners, communities, civil society, and the private sector, really to come together and to accelerate progress.
It's not just about the numbers, 5 million children dying, but each one of them is a precious child, and we want to do all that we can to save every child.
C'est important parce que c'est le futur de l'humanité. Nous sommes aujourd'hui à un tournant important parce que la majorité de la population sur la Terre devient de plus en plus jeune. Alors si on ne prend pas soin de nos petits-enfants, comment ils vont devenir ces jeunes-là pour continuer à bâtir le monde?
Thank you. So to close us out now, I just would like to give a few messages of thanks. First of all, to UNICEF for that extraordinary video that motivates all of us to action. Also to the wonderful Janie Morency, who has been helping me with this webinar. She works with the Child Health Task Force, which is the group that hosts the Child Survival Action Agenda. And if it's one thing we want you to do after this call is to join the Child Survival Action Movement. Janie will click on that link. It's very simple, takes you to the Child Health Task Force page, and you can join one or more of the action teams. This is the way we'll make most rapid progress on achieving SDG 3.2 in the years we have remaining. It's to join forces in the way you've seen many of our commitment makers do so today. And this is the place to do it. Increasingly, our work on child survival, particularly in the post-neonatal period, will be done through child survival action. So let's all get behind it. A thank you to our partners. The Second Global Forum, as Infanta Cristina said, was a collective effort. Here's the organizations that came together to host in Madrid and who've supported this Progress Roundtable today. Special thanks to all of them for banding together for children. I want to thank our wonderful interpreters, Jessica and Catherine, who've helped us through the last hour and 45 minutes from Alboom Translation Services. They did a terrific job. We'll be sharing a recording with you and the wider world later today. We're promoting this Progress Roundtable widely. We'll also be publishing a progress report later this week with all 38 commitments updated. You only got a little sample of 12 today. We wish all of our commitment makers rapid progress in their vital work for child survival action, and we applaud, absolutely applaud, the accountability they have demonstrated in coming together today. We thank all of you for being with us, and we look forward to working with you even more intensely than ever before for child survival action. Thank you for joining us.
Thank you very much, Liz.
Thank you, Liz. Thank you all.
Thank you.
Thank you. Thanks so much.
Thank
Great.
you.
Thank you very
Thanks,
much,
everyone.
Liz, and congratulations.
Thank you.
Thank you, and bye for now.
Thank you.
Thank you, Liz.
Thank
Great.
you.
Thank
This is
you
the
all.
best bit. This is the best
Thank
bit.
you all. Yes. Should take a
Bye.
picture of that.
Bye, everyone. Bye, everyone.
Bye. Thank you.
Bye.
Thank you so
Thank you.
much for
Bye.
joining.
Bye-bye, everyone.
Bye.
Thank you.
Bye.
Yes,
Bye, Dr. Kene. Thank you so much to you and your team.
always welcome. Yeah.